It's a pleasure to spend Friday afternoon with you all, and I'm really thrilled about the list of panelists that we have on our agenda for the day. We have a series of 3 presenters, and our first presenter will be Stephen Crow, who will be introducing our topic. He is currently the Technical Expert Lead and Data Evaluation Liaison at JBS International. He has been there since 2021. He is a person with lived experience, working nearly 25 years in harm reduction, drug user health, HIV prevention and treatment, LGBTQIA+ services, quality improvement, technical assistance, and program development. Formerly, he was the opioid program manager for the New York State Department of Health, and also the quality program coordinator for the State Department of Health in New York, and the AIDS Institute. He has also worked for nonprofits, including Harlem United, National Harm Reduction Coalition, Housing Works, and Cambridge Cares About AIDS, which is now known as the AIDS Action Committee Fenway Health. Currently, Stephen splits time with his husband and rescue pug in Miami Beach, Florida, and Brooklyn, New York. Welcome, Stephen. Our next presenter will be Dr. Valerie Harder. Dr. Harder is a professor in the departments of pediatrics and psychiatry at the University of Vermont, Larner College of Medicine. Dr. Harder is the lead of the Surveillance and Evaluation Core of the VUVM Center on Rural Addiction, also known as CORA, and the director of the Pediatric Health Services Research Team at the Vermont Child Health Improvement Program, focusing her research on measuring the impact of public health interventions to improve physical health, mental health, and substance use treatment outcomes of youth and young adults statewide. Her research team leverages large administrative health data sources to assess the impact of quality improvement efforts, targeted interventions, and statewide policies. In addition, she leads evaluations assessing improvement projects around health systems in primary and specialty care. Dr. Harder received her doctorate in mental health epidemiology and her master's in biostatistics, both from Johns Hopkins University School of Public Health. Welcome, Dr. Harder. Finally, we have Jordan Brandt. Jordan Brandt is the technical expert lead at JBS International with experience in behavioral health policy and technical assistance. Over her career, she has worked with foreign, federal, state, and local governments, healthcare providers, and nonprofits to address morbidity and mortality associated with substance use. She has experience managing all aspects of technical assistance planning, delivery, and follow-up for the Health Resources and Service Administration, HRSA, and the Substance Abuse and Mental Health Services Administration, SAMHSA, grant recipients, including Substance Abuse Prevention and Treatment Block Grant and State Targeted Response to the Opioid Crisis Grant recipients. She also brings experience working for grassroots nonprofits as a former chief of staff at North Carolina Survivors Union, a national leader in harm reduction and advocacy for people who use drugs. She holds a master's in public policy, concentrating in behavioral health from Brandeis University. Welcome, Jordan. So today we are focusing on rural SUD stigma. It is an interest of many of us as we struggle with our own challenges, support the advocacy of others, and really hope the best for our community when it comes to stigma reduction in this area. So without further ado, I turn the floor over to Stephen Crow.
Great. Thank you so much, Lori, for the introductions, and really excited to meet you all and to present to you today to talk about addressing stigma. This is certainly a topic that we at JBS International, as our core technical assistance provider across the country, I don't think that we have any grantees that haven't identified stigma as an ongoing and prevalent, persistent issue in their rural communities. And so this is an ongoing topic that we always are talking about with our core grantees, as well as with the partners and consortium members or other folks that are working along with grantees throughout the community. And so we certainly will cover as much as we can in the time we have today. We know that There could be full conferences on the topic of stigma. And there's so many different directions that we can go in, so many different intersectionalities when it comes to stigma. And so we want to really focus in on sort of the high level points. And then we certainly want to also try to hear from you, encourage you to throw any questions or responses or reactions in the chat if you like. We will have time for Q&A, of course, and discussion, but please don't hesitate to throw anything you like in the chat as well. So Jordan, if you don't mind moving forward with the slide. So as far as just what we'll be covering today, the learning objectives. So Jordan and I are going to start off by describing just some of the various types of stigma. We'll then hand it over to Valerie, who will then provide you with a short presentation of the work that they've been doing at the University of Vermont. She'll then kick it back to us, and we will continue onward with focusing on understanding the relationship between stigmatizing language and wellness outcomes for people who use drugs and people with substance use disorders, and then to reflect on ways in which we may all contribute to and or combat stigma in our communities, focusing there on strategies for how we can be champions of stigma reduction throughout our communities as well. Next slide, please. So what is stigma? There's a lot of different definitions that we could potentially pull from through research and all sorts of sources. We chose to go with the American Psychological Association definition on stigma, which outlines that the negative social attitude attached to a characteristic of an individual that may be regarded as a mental, physical, or social deficiency. The stigma implies social disapproval and can lead unfairly to discrimination against, I'm sorry, lost my slide. Can lead unfairly to discrimination against and exclusion of the individual. So this may be very much in line with what you're familiar with as in regards to the definitions of stigma. I'm sure there's a lot that we can really add or build onto this, but this is really going to be our working definition for our presentation today. Next slide, please. So ways that stigma can manifest. Stigma can definitely emerge in all sorts of different capacities in different ways. And so we really want to be able to focus in on some examples here of these 7 different types of stigma. And so public stigma can really happen when the public endorses any sort of negative stereotypes and prejudices that might result in discrimination against people with substance use disorders, mental health conditions. This is really looking at sort of the community-driven or community-level stigma. You can think of this as almost like a macro level stigma, if you will, that may happen sort of on a broader scale. Another form of stigma is self-stigma. So this can look how someone may internalize or individualize stigma towards themselves. When someone who may have a substance use disorder, mental health diagnosis, or anything else related to their identity, how they may internalize stigma and maybe even feelings of shame. We certainly may see this manifest itself in, at times, even in 12-step meetings, 12-step circles, mutual aid groups, for example, where there may be a lot of kind of internalized stigma that people are holding on to because of maybe behaviors that they engaged in when they were a person who uses drugs before they maybe began sort of a recovery process. And so there may be a lot of stigmatizing language that individuals may use to sort of self-harm, even if it's unintentional. But it's definitely something that is important to be conscious of and help people to sort of navigate some of those really complex feelings that they may have surrounding it. Third example of stigma is structural stigma. So this can also be sort of somewhat at a macro level. This looks at sort of more the institutional and public policy sort of looks of structural stigma. So this could be how systems might work against people, different populations, different communities, different identities, where systems or institutions or organizations might contribute to stigmatizing or discriminatory behaviors. Perceived stigma is our fourth example. This is really the belief that others may have negative feelings, perceptions about what stigma might look like. So this could look like, I have once gone into that healthcare facility and felt discrimination or stigmatized by the receptionist at the front desk. And my perception is that if I'm going to return again, even if that same person's not there, that I will still be met with the same level of discrimination or stigma within that space too. So perceived stigma can really be looking at more of the beliefs of or the expectation that because I'm a person who uses drugs, I'm going to be stigmatized. So it's sort of the expectation that one might have, the anxiety even that to the anticipation that stigma will be experienced. Label avoidance. So this is when a person chooses not to seek care, services, treatment, or other resources, or get their needs met because they're avoiding being assigned any type of stigmatizing label. And label avoidance is really one of the most harmful forms of stigma because then it can lead to folks not getting care, not getting resources, potentially putting them at greater or higher risk of things like overdose or chronic diseases and infections. Stigma by association really occurs when the effects of stigma are extended to someone that may be linked to an individual with a substance use or mental health disorder, and is also kind of known as associative stigma as well. And then lastly, health practitioner stigma will also go a little bit further into. This can take place at any time that a healthcare professional allows stereotypes or prejudices about substance use disorders, mental health disorders, and more to negatively affect a patient's care. And so we'll elaborate on that a bit further. So you might have familiarity and you've probably observed at times these forms of stigma. And at times, maybe you yourself, and I can certainly say that there's been plenty of times that I can reflect back on my work and still continue to reflect on my work about how I may be contributing to stigma through the language that I use or the activities that I engage in as well too. So I think it's really helpful for us to have conscious and awareness of this so that we can work towards mitigating and minimizing any contributions that we can have towards stigma. Next slide, please. And I'm going to pass it over to Jordan.
Thanks, Stephen. So yeah, knowing that we were going to be surrounded by a group of public health, public policy, academic leaning folks, and some community folks, many of us can't help ourselves. We love a good framework. And so this is a stigma framework that was released in 2019. I'm guessing the text is pretty small on your screen. So I am just going to put the link to the article that this originally came from in the chat. But I think this is a really helpful way of thinking about where stigma comes from, what it actually looks like, and then the levels at which we see stigma. So within the white box on the screen, at the bottom, you'll see the drivers and facilitators. The drivers really being, what are the motivations behind our stigma? Is it fear? Is it social pressure? Is it blame? Is it wanting to scapegoat something? And then we have facilitators, things like cultural norms, our legal context, which can make stigma a little bit easier. And then where does that move from? It moves next into stigma marking. And so that's actually what are the determining factors on which, we're making these judgment calls. And you'll see on one side, health conditions, and side markers like race, gender, sexual orientation. Stephen talked earlier about the intersectionality that can play out with stigma. And so what's great about this framework is that it's a general health framework, not necessarily specific to substance use. So you can really see how other factors can then play into worsening stigma. And then we start to see the way that stigma then manifests. So it's what what are the experiences of people as it relates to stigma? And that's really what a large part of what Stephen covered previously about the different types. And then we have actual outcomes. So you have affected populations, you have things like laws and policies that end up being put in place as a result of stigma. And then at the bottom, you really see that all of this is wrapped up in the different levels of stigma. So individual being that internalized self-stigma that Stephen talked about, interpersonal being something that plays out between two people, can be friends, family, social networks. Organizational stigma being what we see take place in social institutions, workplaces, clinics. Community then being at a more macro social level, and then going into public policy and actually that systemic structural piece of how does this play out in laws and policies. And so we will chat about that a bit more as we go on, but wanted to provide this background before Dr. Harder goes into some of the research that they've been doing at UVM. So I will pause there before passing it to Dr. Harder and just see if anyone has any questions. Okay, Dr. Harder, I'll pass it to you.
Thank you. I love a good framework myself. Thanks, Jordan. I apologize. I have a little bit of a residual cough. So I'm so happy to talk with you all today. Thank you, Lori Meshke, for inviting me. And it's good to see you all, JBS International, again. We've been working together for several years, so this is a really nice collaboration to be continued. As Lori mentioned, I'm from the Center on Rural Addiction at the University of Vermont. And as an epidemiologist and the head of the Surveillance and Evaluation Core for the University of Vermont Center on Rural Addiction, I work with large data sets. Some I collect myself, which is what I'm going to present to you today, and others that I look at administrative data sources like claims and electronic health records. But it's always nice to collect some original data. And so today I'll speak to you about our rural substance use disorder stigma among practitioners across rural areas. It was really nice to see all of the different types of stigma. Stephen, thank you for presenting those. I'm going to share results from our published national report on rural substance use disorder stigma. I do not have any disclosures or conflicts of interest. The learning objectives today for this part of the talk are to be able to name top rural provider identified barriers to treating patients with opioid use disorder from a national perspective. Also to list preferred and non-preferred terms used by rural providers to describe people with substance use disorders. And finally, to identify stigmatizing beliefs about opioid use disorder and also medications for opioid use disorder, or MOUD. The University of Vermont Center on Rural Addiction, UVM CORA, is the Rural Center of Excellence on Substance Use Disorder Treatment. Development of our stigma survey, which I'm presenting today, was in collaboration with the other two Rural Centers of Excellence. First is at the University of Rochester, the Rural Center of Excellence on Substance Use Disorder Prevention, and then the Fletcher Group, which are the Rural Center of Excellence on Substance Use Disorder Recovery. And all of us are supported by the Health Resources and Services Administration, or HRSA, through a grant from the U.S. Department of Health and Human Services. I'll start with a bit of background, just understanding what we already know from published studies on potential rural and urban differences on stigma. There are a few studies that examine the differences in stigma between rural and non-rural areas, not a lot. There's a study by Brown and colleagues who surveyed non-prescribing clinicians nationally that treat people with substance use disorders. And they found that rural clinicians have greater abstinence orientation compared to urban clinicians. They also found that rural clinicians perceive medications for opioid use disorder as less effective and acceptable than urban clinicians. You could see this is a relatively recent study. Also, a study by Franz and colleagues surveyed board-certified physicians in Ohio and found that rural physicians had greater bias towards people with opioid use disorder than urban physicians did. And rural physicians reported practicing in areas with less access to buprenorphine prescribers and harm reduction services, such as naloxone. So these studies add to the evidence. They raise some concerns for us. They suggest there may be more stigma and bias among rural providers related to opioid use disorder and medications for opioid use disorder compared to providers in more urban areas. So with that background, we wanted to conduct a survey, rural substance use disorder stigma and treatment needs. And this would be a national survey, and I'm going to present some of our findings today. The survey was conducted in this past summer, so June, well, I guess now it's 2 summers ago, so June 2023, in partnership with the other HRSA-funded Rural Centers of Excellence that I mentioned. Our survey covered many topics. The full report, which is pictured here, can be found on our website. So that's at the bottom, uvmcora.org. We have many reports on our site, data briefs, short reports. Please check them out. This survey covers so many topics. And so I am only today going to cover the topics that are here on this slide, the 4 bulleted topics. Practitioner barriers to treating patients with opioid use disorder, practitioner emotions while interacting with people with substance use disorders, use of stigmatized language, and finally, beliefs about opioid use disorder and medications for opioid use disorder. For this survey, we recruited a national sample of practitioner respondents affiliated with they are HRSA grantees themselves. This survey was distributed to 794 practitioners the June 2023, and we received 303 survey responses. So our response rate of 38% was pretty good. 257 of which were eligible, meaning that they were practitioners directly serving patients. The practitioners who responded practiced in rural areas across 42 states, and it includes Puerto Rico. And the figure you see here is the visual of the geography of the United States, shows that we do have good distribution of our states across all the United States. There are some missing states in Mountain Time that you can see, and the majority of respondents seem to come from Eastern United States. As I go through the slides and present our results, just wanted to take a moment to say, take a note of any results you'd like to discuss further during the group discussion. Think about things that are surprising to you that I'm showing you, not surprising, or what are you noticing? Our final national sample of clinicians included 110 clinicians, mostly nurses and physicians, and slightly more counselors and other roles like social workers. It's possible that some people in your area actually completed this national stigma survey. Maybe some of you who are clinicians and are awarded similar grants could have completed this survey. I want to point out that the RCORE grantee practitioner respondents were majority white, with 91%, non-Hispanic, 75% were female, and the mean age here was 46 years old. This is our practitioner respondents and their work setting. So here you can see a relatively even distribution of work settings from substance use treatment centers at 22% and primary care practices. We specifically had federally qualified health centers at 21%, which are primary care and many other integrated services. The other category at 18% includes local health departments, schools, or prisons. And then we have a nice distribution from others like mental health, behavioral health organizations, opioid treatment programs. So we had a good range of work settings. This is my first data slide. I'm showing you here practitioner barriers to treating patients with opioid use disorder. We asked participants to rank what they perceive to be provider-related barriers to treating patients with opioid use disorder. And we asked, please rank the top 3 provider-related barriers to treating patients with opioid use disorder in your practice or your organization. As you can see in this figure, the majority ranked time or staffing constraints at 53%, and a close second was stigma or bias at 48%. These are the top 2 barriers that were self-identified. This was surprising to us because when we did state-specific surveys and we asked these questions in Northern New England across 4 states, we didn't see stigma as being self-reported up at the highest, but when we asked nationally, it is up there across these rural areas of the United States. So among our core grantees nationally, it is something we should think about, and it is a top of their concern as their practitioner-related barriers. Here I'm presenting results on practitioner affect ratings. We used a measure called the affect scale for substance users, modified by Dr. Seth Brown, and shown to have good validity and reliability. The affect scale asks participants to rate on a 7-point scale from 1 to 7 their emotions about interacting with a person who has opioid use disorder. So here we have listed affect on the left, a more negative affect in the reddish orange color, and on the right, more positive affect in the greenish color. So overall, practitioner respondents reported experiencing positive emotions. In other words, lower stigma towards people with opioid use disorder, which is a good sign. The mean across all of these was 6.1. So they're promising results. It could be interesting. We're thinking about looking at variations in these results within subgroups of respondents to see if there are areas for targeted improvement. All right, so this is our next set of data where we looked at the proportion of practitioners who report using preferred and non-preferred terms in professional settings. So here, excuse me, we use the National Institute on Drug Abuse's Words Matter site. So NIDA's website stresses the importance of using person-centered language to reduce stigma around substance use. They include information on terms to avoid, to reduce stigma when discussing addiction. These preferred and non-preferred terms are presented here in a randomized list for each participant. Well, here you see them like side by side, but when they took the survey, they were just randomized. Excuse me. So here you can see that practitioners reported using both preferred or non-stigmatizing and non-preferred or potentially stigmatizing terms. The most commonly used non-preferred term at the top is medication-assisted treatment, or MAT. And you all might be hearing this still being used. When many people continue to use MAT, in recent years, NIDA and others have recommended replacing it with medications for opioid use disorder, or MOUD. So why? People always ask. Well, it's our understanding the term MAT considers medication a short-term intervention. By contrast, medications for opioid use disorder, or MOUD, is a standalone treatment for opioid addiction and includes agonist medications like methadone and buprenorphine, whereas MAT was considered part of a larger treatment approach that includes other modalities. So that is why they're suggesting the shift to MOUD. Other frequently used non-preferred terms include relapse. You can see here endorsed by 57% of practitioners. When we talk to our experts in the substance use disorder treatment field, who are clinicians thinking about these terms, they told us relapse can be equated with failure. So they suggested avoiding that term and using return to substance use or simply return to use. So fortunately, as you can see here, most of the non-preferred terms were used by fewer than a quarter of practitioners, but there is room for improvement. You see further down the list, words like addict, which is not person-centered, is still being used by more than 10% of the respondents. It's really flipping the phrase to be person-centered and saying person with substance use disorder or person who uses drugs. Here you're looking at practitioner beliefs about opioid use disorder. We shared 6 beliefs, which you see listed on the left-hand side, about opioid use disorder with participants and asked them to rate their level of agreement from strongly disagree to strongly agree. So all of these distributions are for it's for each one of the statements. So most, or 88%, of practitioners agreed or strongly agreed that opioid use disorder is a chronic medical condition like diabetes. And 77% of practitioners believe that most people with opioid use disorder will, with medication treatment, get well and return to productive lives. And then as you move down, practitioners were more evenly distributed in their beliefs regarding whether treating patients with opioid use disorder is more complicated than treating patients with other chronic health conditions, with similar percents disagreeing as agreeing, and that's right in the middle. It was promising to see down at the bottom that practitioners largely disagreed with the stigmatizing statements that individuals with opioid use disorder only have themselves to blame for their problems at 92%, disagreeing or strongly disagreeing, or are weak at 98%, disagreeing or strongly disagreeing, although there were still a handful of respondents that agreed with these statements. So just keeping that in mind. Here you see practitioner beliefs about medications for opioid use disorder. So we shared these 6 beliefs, again listed down the left-hand side, about medications for opioid use disorder. 73% of practitioners agreed that medications for opioid use disorder are the most effective way to treat people with opioid use disorder. And 66% disagreed that treatment involving unmedicated withdrawal or abstinence should be tried before medications for opioid use disorder. However, 22% were neutral. 12% felt other treatments should be used before medications for opioid use disorder. Despite all the evidence base supporting medications for opioid use disorder as the most effective evidence-based treatment for opioid use disorder currently. Interestingly, nearly 25% felt prescribers should be focused on tapering patients off medications for opioid use disorder as soon as possible. that phrase was in the statement. It would be interesting to discuss why, if we had another opportunity to survey. Here we see 72% of practitioners disagreed that medications for opioid use disorder replace addiction to one kind of drug with another, but 15% agreed with this statement. Perhaps that's behind the desire to taper patients off medications for opioid use disorder as soon as possible. That was one thing we were thinking about. That was my last data slide. Just wanted to remind you all that there are 3 rural centers of excellence, and we're all working on ways to address stigma during treatment, prevention, and recovery. This page has several links to resources you might want to share with colleagues if you want to learn more about stigma. These slides I'll have for Lori can share with you all. So you can click on the links if you want to learn more. And just wanted to alert you all to our Rural Substance Use Disorder Information Center at ruralsudinfo.org. This was developed by all 3 of the centers. Could be a good resource for you all. You might be interested in looking at other evidence-based resources. And finally, I'm always happy to hear from you. Everyone at our center would be happy to hear from you. So please don't hesitate to reach out. All right, I will hand it back or open up for questions. Anything or comments, things that came to your mind as you were listening to the presentation.
I would like to say thank you, Dr. Harder. That was really powerful data, especially since most of them had HRSA funding. I just think that with all the educational pieces and what have you, that these are probably the cream of the crop that you surveyed here, who have access to a lot of information. And I can't imagine what it would look like if it was a more general population.
Yeah, that's a great point. They were all funded by HRSA. So we got our contact list through our program officer at HRSA. And those are specifically targeting to all of the grantees nationally.
I wanted to ask a question about this issue of tapering off, because I know 10 years ago, I really had that mentality when I did my first study with the behavioral health group here in Knoxville. And I was surprised when they told me some people don't taper off. They just do this for the rest of their life. And I was really shocked. But then I listened to Matthew Perry's book and his experience with substance use disorder. And one of the things that he mentions in his book, and I just cringed when I heard it. He talks about his need to get off of Suboxone or buprenorphine, I can't remember which, within 7 days. And that was one of the worst withdrawals ever. And I don't know where this 7 days came in, if he was part of an abstinence program in more of the 12-step tradition. But I'm just wondering, what have been the strategies in moving around this and having a more acceptance and support for people maintaining medication for opioid use disorder?
Yeah, I mean, I would love to hear if there are anyone in the audience who is working directly with patients to bring their perspectives to this. But what I've learned is that it's really patient-centered, and each individual's treatment plan is unique to the individual. And it is not the case where the idea would be, let's focus on finding a date to be off of the medication, and instead working with the patient to see what they need as they're in recovery.
And I was just gonna kind of piggyback off Dr. Harder with that. You know, if an evidence-based treatment or medication is working for someone, And, you know, we should keep them on it. I'm not a clinician, so I can't speak from having a clinical background as a medical provider. I'm not prescribing directly to patients, but you know, just think of any medication that's treating a chronic disease, and how we keep people on it. We don't just suddenly take them off of it. And the reasons why people do, you can guess, is because of stigma or stigmatizing beliefs that this should not be considered long-term. Someone, you know, if they're doing everything correctly, they should be, you know, finishing the treatment or finishing up the medication by, let's say, some sort of arbitrary time frame that's sort of pulled out of thin air. Or I heard someone at a conference tell me this that one time, but with no evidence or data to support it, just sort of hearsay or anecdotal information. And so we're always going to be looking at, as and like any clinicians, looking at the data, and looking at the sources that are the most sort of renowned and respected as far as the decision making that goes into this. And Jordan and I are certainly going to go into some of the myths and facts related to MOUD as it relates to stigma, but definitely the sort of tapering off mentality, unless that's the goal that a patient has set for themselves and they and their clinician have decided together that that's in their best interest, physically, you know, as well as for their substance use disorder, then that would maybe be the reason to do it, but not because it's the clinician's decision of how someone should be determining their sort of end goal for their, you know, if there even needs to be considered like an end goal or sort of end result. Since we know that substance use disorders exist for people for a lifetime. And so treatment may exist for a lifetime as well too.
So can I chime in for just a second? In my experience as someone in recovery, working with justice involved individuals, a lot of times the probation and parole officers will require people to stop in a specific time frame. So I don't know if that's stigma related, but that's one reason why people are like, oh, I have 7 days. Oh, I have 30 days, because if they don't, they risk going back to jail. I'm slowly starting to see that change, but that's been a driving factor in a lot of the people that I work with stopping using the MOUD as a way to maintain their sobriety, is because they have an ultimatum.
That's a really good example of institutional stigma. And it sounds like a non-clinical, non-medical provider making medical and clinical decisions, right? And so we see that very prevalently throughout the criminal justice system. We've seen more and more, you know, prisons and jails that are starting to embrace and support MOUD access, which is really great and exciting, because, you know, why would we prevent someone from taking a medication that they need, you know, insulin for diabetes, for example? But again, it's stigma that people are like, well, insulin or heart disease or HIV or cancer, that's in this category over here, but you're choosing to use drugs. So you're over here, but having a substance use disorder does not equal a choice that someone made. And so I think that it really plays into the reality that you bring up, that it is so many times over the years where I've heard about probation officers and you know, drug court judges mandating or sort of making medical decisions without having any medical background.
And Lori, in your question, you asked about, you know, strategies and shifting some of those attitudes. And I think that's where patient experience and the stories of people with lived and living experience become so incredibly valuable. I put a link in a chat to an old Grand Rounds that I think you can access the recording to by someone named Walter Ginter, who was a long time methadone patient, and at various points throughout his career was essentially forced off of his medication by employers, by all of these different folks, and that led to negative outcomes in his life. And so he's done a lot of work. There are some other really fantastic groups doing really incredible advocacy around medications for opioid use disorder to bring some of that, patient perspective. The National Coalition to Liberate Methadone is another really interesting group doing a lot of advocacy. But Samantha, I really appreciated what you shared, and that it is that criminal justice perspective specifically, because, and this may need to be for another coalition meeting, because it could be a whole topic of its own, but a little known fact is that a big part of how methadone specifically, but later MOUD in general, are regulated in this country has to do with a 1921 Supreme Court decision and nothing to do with medical input originally. And I think very few people know that. We hear about these regulations, we hear about tapers, and the assumption is, oh, there must be a valid medical reason why we should do this. And there's actually like a really kind of dirty history to how all of this came to be. That's really fascinating. But we can chat more about that at the end if there's time, but that's always my fun methadone fact, is a 1921 Supreme Court decision is what basically set up a big part of the clinic system today.
Wait, can I verify what was just said, that if someone is on parole and is using like Suboxone, if they're on it for a certain amount of time and aren't off at a certain time, they can go back to jail? Okay, that's what I thought I heard, but that just,
Yeah, in my experience, that is slowly changing. But
okay.
in my experience, I know multiple people that probation or parole has been like, that's a crutch. You've got this amount of time to get off of it or I'll violate you. Even though it's
Wow.
medically prescribed, they're taking it like they're supposed to.
But
So I
they're
guess,
treating it like it's the actual, like an
Mhm.
opioid.
Yeah.
Wow. Okay, thank you.
If there are no further questions, we will move on to our next presentation. Dr. Harder, thank you so very much. Stephen and Jordan, over to you.
Perfect. Thanks, y'all. Let me just get my slides back. Are those popping up okay for everyone? Okay. So one of the things that really gets to the heart of stigma and is a big part of how stigma is shaped is our understanding of why people use drugs to begin with. And so the list of reasons that you see on the screen are from a variety of research and also some recent needs assessments that have been conducted with people who use drugs. And so, we would all be fooling ourselves if we didn't acknowledge that pleasure is a part of drug use and an important part of drug use, but also that there are a vast variety of reasons that people use drugs, including things like staying awake. I've heard multiple stories from folks who have been unhoused at various points in their lives and will say that stimulants saved their life because stimulants helped them stay awake when they were in unsafe situations and ensured their own, helped ensure their own personal safety. We also know that there is frequently a culture around drug use and that really varies from community to community, but it can be a means of connecting with others. I know UT is the main grantee to be more productive. We've all seen, probably research or maybe just seen it being in a university library around finals time and hearing stories of, Adderall or other things that people share because they're trying to keep up. Another piece is also emotional and physical pain or loss or traumatic memories. And it is really difficult, especially in our rural communities where sometimes substances are more easily accessible than other treatment supports or mental health supports to help cope with some of those pieces. And then the other one, which comes from a needs assessment that a colleague and I conducted, was to be a better parent. That one really struck me when we saw that come up, and it was from people who are parents who are working multiple jobs, who are just trying to get by, rarely have time for themselves. And so they were saying that their substance use helped them actually keep up with their kids, be more present for their kids. Normally, when we think of drug use, especially among parents, which is so stigmatized, it is, wow, you must be a really terrible parent for using drugs while being around your children. And so I was thrilled because one of my colleagues is just finishing analyzing some data from a 2024 needs assessment in Hamilton County, Tennessee. So more, coming forth soon. But these were some results of his needs assessment, looking at reasons for drug use. So this is from a 439 person sample size of people who had used drugs in the last 3 months. And they were asked to list the reasons for their drug use, and you could check, as many as possible. And so 71% said that they were using drugs to manage stress. 63 said they were doing it to avoid withdrawal. 57 said they were using it to ease pain, and 56 said they were using it for pleasure. And so I will admit, I was surprised to see that pleasure didn't even make it into the top 3. And so, right, if we're asking people, okay, well, why are you using drugs? That can also help answer what sort of supports do you potentially need to stop if you want to stop based on your, own goals. The other piece that sometimes gets really conflated when thinking about stigma and when we think about, this field is, what is the difference between people who use drugs and people with a substance use disorder? And so the stats that you see on the screen are based on the 2023 National Survey on Drug Use and Health. The circles that you see on the left side are actually proportional. So the big blue circle is the entire US population. The red circle, which represents just under 25% of the population, are the number of people who have used an illicit drug in the past year. So I intentionally excluded alcohol from this, just, for clarity. But so about, 1 in 4 people used an illicit substance in the past year. And then for people who acknowledge, yes, I used, an illicit substance in the past year, they then get questions based on the DSM-5 criteria for a substance use disorder. And if you say yes to 2 or more, the survey then categorizes you as someone with a substance use disorder, which is about 9.6% of the population. And so this is really important to think about from a stigma standpoint, right? Like, a positive drug screen does not necessarily equate to a substance use disorder. It might be something that prompts a formal, assessment, but it also thinking about in our rural communities where we know we have potentially a shortage of services. How do we triage services for folks based on what people want and what people need? And so really thinking about, how do these 2 concepts play into stigma? Because it is really easy, I think, sometimes just to make assumptions about where someone may be with a substance use disorder, when in fact they might just be someone who uses drugs. And next, I'll pass it to Stephen.
Thanks. So just really keeping on the topic that Jordan emphasized around people with a substance use disorder, to think about why some people do have a substance use disorder, kind of what uniquely might sort of differentiate them than sort of the general community of people who use drugs. So there's really several risk factors that may increase the likelihood of someone experiencing a substance use disorder and can really escalate the severity of that substance use disorder. So there's about a 50% estimated genetic influence, so like family or genetic influence, that can really come into play with substance use disorder. And individuals who, and I should say also over a third may have adverse childhood experiences, and around half may have co-occurring mental health disorders as well too, or learning disorders. And so these really can play strongly into someone's substance use disorder diagnosis, and also childhood access to drugs at a very early age, like with their first use, is one of the most profound risk factors, with over 90% having initiated use before the age of 18. And so if for those who do experience drug use at a very early age, it certainly increases the likelihood that they will be diagnosed with a substance use disorder. And then, other reasons include dislocation, so like moving out of your community or your comfort zones or your environment, being disconnected from people around you, sort of disorientation from your familiar environments. Those can all really play major factors in why individuals may experience a substance use disorder. But then there's some other factors that might include things like emotional pain, criminalization of drugs if someone is in and out of the criminal justice system because of drug use, and the sort of cycle there where let's say that they've sort of stopped use while they've been incarcerated, and then upon release begin using trying to potentially use the same volume in which they were using before they were incarcerated. That's when we know that data and research shows us that folks are at the greatest risk of opioid-related overdose if it's an opioids that they're using. And then there's some lower measures of social factors, such as economic stability, access to quality education or healthcare, living or existing in a healthy and safe neighborhood or home, and having positive relationships. So like all of these components, you can really think almost of, how optimal someone's social determinants of health are, may really help to identify or demonstrate how an individual could ultimately end up with a substance use or opioid use disorder. Next slide, please. And so Dr. Harder really kind of spoke to some of the avoiding stigmatizing language piece on her slide when she shared as far as health practitioners, but we included this, and I think this is pretty much the same. I believe this is the same link at the bottom here, the Words Matter link that was also included in the report too. So really encourage you to check that resource out. We will also get our slides to Lori to pass along to you as well. But, I think something that's really important to emphasize here is that when thinking about the language that we use, it really sort of builds upon, what we're personally exposed to throughout our life and in our social circles and community, our access or lack of access to education and resources, the work environments that we're in. Also, if we're a person with lived experience or living experience too, if someone has been through a lot of 12-step programs, there's certain terms or language that they've become accustomed to and familiar with using. And so I want to recognize that there's terms in here that we identify in the sort of these hurt column that you will hear, of course, probably from patients or clients or people in community that you work with that they use to describe themselves, someone who may identify themselves as, I've been in recovery for, 30 years, and I am, once an addict, always an addict. And so then how much is that contributing to the concept of self-stigma that we were talking about at the very beginning of this session? And so far be it from us to tell someone how to self-identify, but it does give us an opportunity to help people to reflect a little bit more on why they continue to use self-stigmatizing or self-shaming language. But we as providers, we as people, running programs or providing services in the community, there's a lot that we can do to be conscious of this, because you may have experienced at times where you, whether or not you yourself are a person that is in recovery or a person with lived or living experience, you yourself may have, kind of felt these words sting a little bit when they've been targeted towards you, or maybe you've seen someone react in a sort of nonverbal way when you've used a term that maybe it just didn't sit too right. It's sort of those ouch moments that we think of. So we just included sort of this list here to think about. We recognize that it's taken a long time in our field to get to the place where people can finally embrace addiction as a disease. That isn't to say that we should do away with that, but maybe we should start moving towards substance use disorder as a disease, or opioid use disorder as a disease. And that takes time, and it really is, it can be a huge cultural shift. It's almost like unlearning the things that we've always known, which is exactly what I remember doing when I went to school to get my social work degree after working in harm reduction for many years. I felt like, I had to unlearn a lot of stuff to kind of, finish my exams and everything. So, so I think it's just really important that we remain conscious of the language that we use that can either hurt people or help them. And then how can we empower people to use more positive and affirming person-centered language as well too, knowing that we don't have to be perfect all the time and that we can continue to evolve with our use of language.
Yeah, right. And sometimes it's about our audience, right? Like just taking who we're speaking with into account, because you're all involved in an ARCOR consortium. I'm guessing, people really look to y'all as leaders within the community, as people with a lot of knowledge in this area. And so like Samantha, you mentioned earlier about like working with parole, and I'm guessing you may change some of the language that you use depending on if you're working, one-on-one with someone versus whether you're talking to the parole officer. And there might be language, right, that like if you use around the parole officer, it may just continue to like reinforce some of the parole officer's preconceived notions. So I think it's also thinking about like, am I having a casual conversation with someone? Is there terminology that I can use for someone with lived and living experience that's gonna, make them be more comfortable around me versus am I in kind of educator role? And so my litmus test tends to be if I don't think someone if someone would not want to hear a doctor saying it to another doctor about them, like, then I try not to use that language in an educational context, if that makes sense.
Thanks, Jordan. I did want to talk just a moment. So just sort of the pejorative or negative language that we may sometimes use or sort of catch ourselves using, is that we know that when people use language that's really intended to disparage or belittle people or a group of marginalized or vulnerable individuals, we do really think of that as harassment and discrimination. So like really kind of scope out and take a more aerial view of, when you think of some of the most discriminatory terms that you've heard throughout your life, have people use them in ways that are meant to help, or have they used them in ways that are meant to harm or sort of other themselves from that individual or their community? And so publicly, we might refrain from, or most people might refrain from using sort of negative expressions that may describe someone's identity their race, ethnicity, their religion, their origin, their sexual orientation, their gender identity, any disabilities, etc. So we may publicly do that, but then when we use negative words, like the ones on the previous slide or the ones here, we are causing harm. And so our we kind of use this as an opportunity for us to think how can we be more mindful, and it's almost like practicing more mindfulness to be more conscious of it, and to get to a place where you become almost these sort of community champions or ambassadors of stigma reduction throughout the community, and how that can kind of, help people can start sort of recognizing you for that in your conversations as well too. If you're having a conversation with someone else and they keep saying the term, addict, addict, addict over and over and over again in their conversation, and it's just kind of, you start noticing that more and more. When you're also engaging, how are you then saying, oh, a person in recovery, a person in recovery, a person in recovery, and so it's almost like it's a non-confrontational way, but it's a way where someone might really pick up. And I've found myself, especially with law enforcement, doing that sort of exercise in meetings I've had when I've really been brokering relationships with them, because of the needs of the community, the support that the programs that I was running needed. And I remember a police chief once kind of stopping at like 10 minutes in and was like, you haven't said the word drug addict at all. You keep saying person who uses drugs. And I've realized I just keep saying like druggie and drug addict the whole time, or those people that are using drugs. And it was like, well, I think we need to be mindful that these are people too. They deserve, our respect, and they really deserve to be treated just as equally. So how we can be more conscious. And that was an interesting moment I recall from many years ago whenever I was working with the local police chief to talk about, providing the lock zone, at their roll calls for their team. So it's really important that we remain conscious of knowing that this is really about, always thinking about how we can improve our efforts to become more person centered. Slide.
Thanks for that, Stephen. Yeah, my story on person first language is that my husband is an editor by training. And so when he hears me talk about person first language, his editor brain went to, oh, but it's an inefficient use of words. It's a mouthful. And it was only once we started talking about, no, like this does matter because there are actually very real outcomes tied to this. And so that's what we're going to talk about a bit next is, how sometimes, it's hard to jump in or correct. I like, Stephen's example, because sometimes just mirroring better language is enough, but we know that there are very real outcomes. And so next we're going to share a couple different studies that look at the different levels of stigma and see how it has actually manifested. And so this first study is from something called the Rural Opioid Initiative. If you're not familiar with it, I highly recommend looking it up. Their research is really incredible and is specifically rural, which I really appreciate. And so they spent a little bit over 2 years conducting surveys with over 2,600 people who reported opioid use in the previous 30 days in rural areas across 10 states on a variety of topics. And one of the things they asked about was felt stigma. How have you felt stigma in your community? Have you felt it with loved ones? And based on the responses, they then looked at rates of non-fatal overdose. And for people who reported feeling stigma, that was then associated with higher rates of non-fatal overdose for people who live in rural communities. So this is clear how on an interpersonal level, when people are experiencing stigma within the community, there are specific like detrimental outcomes. And obviously they could only research non-fatal overdose. Who knows, what this could look like if we could factor in fatal overdose then. But clearly tying felt stigma to higher risk of non-fatal overdose in rural communities. Looking then on an organizational level, this one looks at it on a clinical level. There was a study done looking at almost 50,000 patient records among almost 30,000 unique patients. Have the exact numbers up there on the screen, and the citations are at the bottom. So we'll send you these slides. You're welcome, to look up the studies. But researchers looked at almost 50,000 medical charts for patients with diabetes, substance use disorder, and chronic pain that were written by almost 2,000 clinicians. And they then examined use of stigmatizing language within these patient notes. And they found that stigmatizing language varied by medical condition, with the most stigmatizing language being used for patients with substance use disorder. And that stigmatizing language was most often used to describe Black patients. So that's where some of that intersectionality that we saw in the framework really starts to come out. And so the recommendation out of this was saying that we really need to be training clinicians to minimize stigmatizing language in health records, to improve patient-clinician relationships, but also that by putting stigmatizing language in notes, it was a way that bias was being transmitted from one clinician to the next. And then the next one that we pulled was one relating to public policy. So how does this then potentially become like systemic within our society? And so I guess one of the silver linings of COVID was being able to do a lot of research around changes in methadone take homes. And the article linked here is written by a group of researchers who did quite a few different studies related to take homes, but they looked at a bunch of opioid treatment programs specifically within Tennessee from October 2020 to March 2021, including discussing their research with the medical directors. And that part of the issue that they found was that without daily dosing, for-profit opioid treatment programs were seeing a financial loss. They were structured and financially incentivized to require in-person daily dosing rather than providing patients with take-homes. And so actually some opioid treatment programs rolled back take-home dose exemptions that were allowable at the federal level, and despite public health and social distancing guidelines, because that is what was better or needed for their bottom line. And so talking, like we were discussing earlier, reasons for people potentially tapering or what their MOUD course of treatment looks like. Sometimes money and reimbursement plays a really big role in that, which is exactly what this looked at. And it was also then interesting to me to see in Dr. Harder's slides earlier about how 37% of the clinicians interviewed were also concerned about diversion and illicit activity, because what shows up in this study as well, and was reinforced by other studies, is that actually diversion is not in reality maybe as big of a concern as some people would think, that with the increased take homes that became allowable under COVID and have now been made a permanent rule, issues of diversion did not come up as frequently as some people may have suspected. And so now that we're already kind of on the topic of MOUD, Stephen's going to chat a bit about some of the myths and facts.
Yeah, we've already kind of touched a little bit on some of these, and one of the myths that I didn't include here that when you just mentioned around diversion is that um, you know, if an individual, for example, does seek out access to Suboxone on the street, it's usually because they need it and can't access it from an actual treatment facility that they may not physically be able to get to, or they don't have the financial or insurance, coverage means to access it. There might just be barriers, even transportation related, or fear of going back to the same place again that they felt stigmatized in. And so people will seek out the drugs or the medications that they need by any means necessary if they want them or need them or crave them or desire them. And so we have to accept that that's just the reality. And it doesn't necessarily, it means that we can look more at what's wrong with the systems and how can we improve the services and improve quality access for folks rather than pointing the finger at the person that's just doing the best they can to get their needs met and saying that they're actually the problem. The reality is that usually in that case, it's a system that needs to be looked at and examined much deeper. And so, this really, we wanted to include just some examples of some common myths related to MOUD that you might be familiar with or that you've probably heard of. And so, one that we've commonly heard over time is that MOUD substitutes one substance for another. It's replacing one drug for another. So if you're giving if someone's taking heroin and then you're putting them on Suboxone, well, you're just kind of keeping, the same problems, right in front of the individual, which is just simply not true. MOD does use longer acting and safer medications to help people overcome what could be more dangerous opioid use or opioid or drug using practices. And so many studies really show that it's proven to reduce all sorts of risks related to opioid related deaths. It can help keep patients healthier. It can reduce criminal activity. It can really affect recidivism for sure. It can also help prevent diseases such as HIV and Hep C. And so these are great benefits that people can gain over time if they're, regardless if they're using methadone, buprenorphine, naltrexone, sort of whatever the medication is that works best for them and their treatment goals. Another thing is that MOUD should not be long-term. That's a common myth. And so we talked a little bit about this earlier as far as the taper idea and the concept, so I won't belabor this too much, but it's really, again, the decision between the clinician and the patient. There's never a one-size-fits-all approach to any medical treatment. If, let's say, someone is diagnosed with cancer, they're not going to go through the same treatment as the person next to them that's also diagnosed with cancer. It may look very different. And if a patient is benefiting from a medication, they should absolutely remain on that. And so we've got a lot of data, a lot of research available beyond just the reference that I include here. And so we're always happy to provide more resources to support MOUD myths and facts. We have a couple more on the next slide. So another common one is that MOUD is a bad moral choice or failing and that it prevents people from true recovery. You really hear this sometimes in, 12-step NA type settings sometimes. But the reality is that, as we've talked about, addiction is a disease or SUD is a disease, not considered a moral failing. And therefore we should be treating OUD with medication. It can be treated and managed with medication, much like other chronic medical conditions. The next is around requiring people to taper off. We talked about this around research that requires people to stop taking life-saving medications. It can be very counterproductive, and it can dramatically increase risk of folks returning to use or increase risk for overdose. And then that MOUD is not effective because it does not immediately end drug dependence. So we're not thinking of MOUD, and we should not think of MOUD as this is just the cure-all. Like this is going to fix everything, right? We know that it's chronic addiction and SUDs can be chronic disease, which means it's long-lasting. Individuals may be in, recovery for a really long time. People are in it for their lives. And so, and people might return to use. And again, that's not failure. That's a lot of conditions that may have been going on in the individual's life at that time. But medical treatment for OUD can be compared to other common chronic conditions and forms of treatment as well too. And so it's just really important to recognize that, we should not ever think of this as it's a medication that's just going to suddenly fix someone. What it could do is that it maybe help someone to start achieving the goals in their life that they finally wanted to work towards achieving. And so there's great benefits to providing people with access to life-saving evidence-based medications such as MOUD. Next slide, please. So I did want to talk for a moment just about the role of peers in this work. I have in the past run several harm reduction outreach teams, syringe exchange programs where we had peers working for our program, people with living or lived experience, people that were currently or formerly individuals who use drugs. And this is also something where a lot of the ARC-Core grants over the years, there's been a lot of growing emphasis over time with the role that peer support has. And peers are really vital, individuals that are sort of from communities working for communities, sort of nothing about us without us, sort of ways of thinking about the work that we're doing, and how we can really empower individuals with lived experience to support individuals in the community that may need, to feel supported by someone who knows what it's like to sort of have a substance use disorder. Everyone has their own story, everyone has their own journey. And so I think that it's really important that we do recognize that in defining, the work of a peer, we have to be able to differentiate a little bit between sort of an individual's personal pathway and then the chosen field that they're working in. And this is where there becomes a lot of gray area in programs, right? I have worked with some ARC-Core grant recipients where I've asked like their peer support specialists, what evidence-based curriculum or practice are you using to do your engagement in, the local county jail? And they said, well, my own lived experience is the evidence. And it's like, oh no, there could be a lot of harm done here. There needs to be, a curriculum, for example, that could be in place, or maybe some more training and skills, because it's great to be able to employ an individual with lived experience, but then how are they supported in their work? And so a person in recovery might be volunteering. They may have their own pathway, like, is the one way that worked for them. They may have sort of a self-defined moral compass of what works best for them. And then they may receive some informal mentorship, right? They have a sponsor at their NA meeting, for example. A peer support specialist is someone that would become like a certified peer, right? Someone who gets the professional training, learns about all the different pathways to recovery, learns that there's not one trajectory that everybody should follow. That there's many different pathways, and that we want to recognize and embrace that everyone's going to be at their own pace and is going to approach this at the times that work best for them. There becomes more ethical considerations, right? Because peer support specialists are working for organizations. And so there are ethical considerations because they are becoming sort of the face of the organization, if you will, when they're going out to do outreach or engage with folks in different settings too. So there's ethical considerations when it comes to how much an individual is using their own personal journey and trying to say, well, if I did it, you can do it too, which is something I've heard so many times. And that puts a lot of pressure on the individual hearing that, receiving that, right? And so it's important to be able to provide the space where individuals that have done this work, that are doing peer work, that have lived experience, that they receive supervision and support and coaching, whether it be individual, clinical, a supervisor, to really just talk through it, because it can bring up, if someone, let's say, has, been in, recovery for a couple years and they're diving right into this work but don't have any ways to sort of process the impact of this work on their own personal work that they're doing as well too, then that can have really negative, that can lead to a lot of negative consequences for then the engagement activities that they do in the community as well. And so it's important to be able to provide as much support as possible, tapping into the resources at the local level, but also tapping into the resources that exist on the national level. And we've got some resources at the end of this, to help you get connected, through our core, through the technical assistance team. We have a really great subject matter expert named Donald McDonald. He runs our peer office hours, where peers from our core programs all across the country can jump in virtually and sort of just process the work that they've been doing. Like, talk about what's this work bringing up for you, and how do you balance your own personal journey with the work that you're doing in the field too, because it really can bring up a lot of complex, unexpected things for many people too. So we want to be able to recognize that there's the importance of having the ability to know where there needs to be some boundaries. And this also goes back then to like knowing your audience too. What type of boundaries that we need to make sure that we're setting with folks as we sort of put on and take off our different hats and become chameleons to our different audiences throughout the community. Next slide, please. And so we want to just give you some strategies to think about of how you can become even more of a champion to support stigma reduction. So, there's many things that we can do. So education and awareness, how you might be helping to combat any misinformation that people might have, giving data, giving evidence. The other thing that I'll say is, like, I don't just mean quantitative data, anecdotal stories, having people sort of, tell their stories is great, but really emphasizing, this is my story. I can't speak for everybody that's ever used drugs, so it's really important that we acknowledge that. But for some, for like law enforcement, for example, the data and the evidence, if you give a research paper or show some numbers, that may not always be the most compelling thing. But maybe they had a child that passed away from an opioid overdose, and there's something that's more interpersonal that they could benefit from hearing or talking through as well, in relating with other law enforcement that have maybe experienced the same sort of losses and what that's brought up. So education awareness, I always encourage folks to think outside the box, with the different approaches that can be taken. And then we've talked about the importance of person-centered and inclusive language. Storytelling. So again, I jumped ahead, empathy, storytelling, the testimonials can help connect, training like this, professional development, the ways that you collaborate, providing accessible and non-discriminatory services, so thinking about like, how do we make sure that the first person that people meet when they walk into our building is welcoming, and that they don't feel stigmatized because they're walking in and they're, seem like they're nodding off a little bit. Is the receptionist, whispering something that's sort of judgmental of that person nodding off? Or are they going to check on them and see if they actually might be at risk of opioid-related overdose, for example? And so, making sure that we are providing accessible and non-discriminatory care and services. Support groups and peer networks, are really important too. Any sort of media or social media engagement. We worked with a company by the name of Drake Cooper to develop the Be There anti-stigma toolkit about 2-ish years ago. And so we've had a lot of grantees that have developed anti-stigma campaigns over the past couple of years through social media and media engagement. And then lastly, celebrating any positive change. We're so used to, to applauding positive change in recovery circles. Someone saying, I'm 10 years clean, and everybody applauds. And then how do we show equal recognition for positive change in sort of through the whole spectrum? So from a harm reduction perspective, someone I've, been using, unsterilized syringes, for the past 3 months. And I finally got connected to the syringe exchange program where I'm now using sterilized syringes and I'm putting myself at much lower risk. How do we then say, oh my gosh, that's amazing. Now you're connected to a organization that can also connect you to testing and naloxone and counseling. And it's now like an entry point into so many more resources if and when you're ready. And so we need to recognize that celebrating any positive change can happen on a very broad spectrum. It doesn't have to just look like, well, we're only going to celebrate when someone's finally at the recovery stage or when they finally decide to go to treatment. We should recognize that and celebrate that. But let's not forget that there's a lot of individuals that still need all the support to really celebrate any change that they make.
And sometimes, right, those positive changes are going to not have anything to even do with substances. I still remember when I was working in a syringe service program, one of the staff came in, they were so excited. They had filled out their tax forms and paid their taxes on time for the first time in 8 years. And they were still using drugs at that point. And, that's like really hard for anyone. I hate paying my, the forms. And so but that was huge. And they were so incredibly proud. And so I think sometimes a great way to think about combating stigma is also how do we think about, goals that are not just about what is or is not in our bodies, but about, how we're building relationships in our lives, how we're making contributions in ways that are meaningful.
And so this is really a slide to help you and anyone in your community or your colleagues to sort of reflect. And anything here, feel free to steal shamelessly from what we're giving you once we get these slides to Lori and you take them. We do ask you credit where it came from, of course, but if you find that some of these slides will be really helpful for the education that you provide, as you think about how much of a stigma reduction champion you want to become in your community, or maybe you already are and you want to really just sort of amplify that skill set. This really, I've used this in trainings with peers, with law enforcement, with providers, just to sort of think about like, where do you find yourself? For example, the first one, do you believe that substance use disorder is a choice, or do you believe that it's a health disorder? And so where would you kind of, put yourself on this sort of values-based continuum? Do you believe that MOUD is a crutch and it's really not true recovery? Or do you believe that MOUD is a form of evidence-based treatment and is recovery? And so these are different examples where you can really help people to think about, like, where do they currently see themselves on the spectrum? This is also a really interesting exercise to maybe even like go back, to 6 months later with some folks that, let's say, maybe want to do some self-reflection or team reflection even, to see like, after some training, and then I, started integrating what I've learned into some of my engagement activities in the community, or when I've done intakes at my facility, or other activities too. Have I seen myself sort of shift from where I felt like I was at one point? Because I'm telling you, the way that I think about things now look very different than how I maybe thought about them 10 years ago or 15 years ago in my work too. So we are all constantly on a pathway of evolution with the work that we're doing. And so there's no judgment put in here. If you find yourself kind of closer to the left side of things, that's all right. It's about starting with some self-reflection and with the goal of moving towards creating a more embracive community that looks at how stigma is negatively impacting people's ability to access the resources and support that they need. Because by reducing stigma, we know that that ultimately is going to help to save lives, because then people are going to be willing to access services, get the care and support they need, and be willing to engage with us more too. It takes time. It's a lot of work. we have no expectation that the Art Corps grant, no matter how long it is going to sort of check off all that, we address all the stigma, check that off our work plan, we're done. We know it's just an ongoing process too, and constant training and growth and development is essential. So just really encourage you to think about ways to self-reflect as well. So with
And that, right, like, and sometimes, Stephen, right, like, I'm guessing on this, people also backslide at different points.
Yep.
Like, I have definitely found myself doing that at times. I do trainings on stigma, and I still find myself sometimes thinking really terrible things. It's hard, right? We go and we're in these environments, but then I scroll through social media or I watch something on TV and we're inundated with society's views about all of this. And so, I've definitely caught myself when I'm, working in programs, whether it's participants or staff members. Sometimes you just sort of catch yourself. And so just hopefully all of us can give each other and ourselves some grace in those moments, knowing that this is something that we're all working on.
Mm-hmm.
And so, yeah, with that, really curious about any questions, thoughts, yeah, really anything that you want to share.
Hello,
And thank
this is
you
Liliana
both so
Urbano.
much. Liliana, I'm sorry. I was just saying thank you. I'm going to turn the floor over to you.
Sorry, let me know if I'm going over time. I don't know where we are at this point. Thank you so much. This was so useful for me. I work for UT Medical Center, and definitely we see this population every day in a big volume. And I wanted to ask you, what are your recommendations in terms of addressing stigma, in terms of best practices, how we address stigma from healthcare providers, physicians, nurses, etc. What is the best way to address it in a hospital, understanding that sometimes providing, 1 hour long trainings is not suitable or even feasible in a hospital setting, and how you measure success, right? Is like sometimes you provide a training on a specific and different topics, and it's hard to tangibly gather data and measure the improvements. It seems that it's more anecdotally, but I'm interested in learning on how to have a more database process.
Yeah, thanks for that.
Will you go first? Because I want to look something up while you're talking.
Oh, yeah, sure. Yeah, thank you so much for that question, Liliana. I think that I think there's several best practices. I mean, some that we certainly covered in here. I think, so I found that over time, and especially when I used to run a care coordination department at an FQHC, we found that there was providers that we knew that needed maybe a little bit more education than others, or that were maybe contributing to sort of a more stigmatizing framework. And so, we would have, at our team meetings, we would maybe do sort of quick educational sessions just on like the use of stigmatizing language and the impacts that can have on patient care. Or, when I was running our care coordination department with our evaluation team, would look at maybe the volume of missed appointments and, really look at drilling down at some examples of, patients that, that we felt maybe because my team would be able to sort of reflect, like my patient navigation team would reflect back and say, oh, I know that this person had expressed to me that they didn't like this experience with this particular provider. So that's why they keep missing these appointments too. So then we as a team would have a meeting and huddle to identify how we could maybe provide some targeted education in a way that didn't feel as though that we were necessarily putting anyone on the spot in a team setting, but maybe through individual supervision. There would be like, hey, I want to encourage you to take this virtual or in-person training. Or, here's some resources that we can make sure that we're all aware of. Everybody gets the same research article that day, on, addressing stigma in medical notes. And, you know, I want you to read this, and, you know, we're going to bring it to our team meeting for some discussion, you know, next month too. So like, you know, read this paper and let's talk about it next month and see what it brings up for you. And then the data piece that you're mentioning, you know, it's definitely hard to measure that. And so, you know, I think that, and Jordan, you may have some ideas around this too, I'm sure, but, you know, being able to kind of do some self-evaluation that is maybe sort of like a, you know, every 6 months kind of thing, or every couple of months, like, especially, you know, there's been education and training sort of between those two opportunities to just kind of gauge people's sort of knowledge, or almost like attitude surveys. And that it can be, you know, this is a self-reflection attitude survey. No need to share the results with us, but it is to help you do some self-reflection on the work that you're doing. You're raising consciousness of it without necessarily putting it on somebody, you know, unless, let's say, somebody is really contributing negatively to the environment and you know that they're being very stigmatizing, discriminatory, then that certainly does, you know, the hope would be then to have sort of a supervisor to have a one-on-one conversation with them about that. But there's, Jordan, I know you wanted to add some more to that. I'll stop rambling on.
Yeah, no, I put a link in the chat to a webinar that we did through our core TA about 1.5 years ago on trauma-informed care. And it features a former ARCOR grantee that's South Carolina based, that was a behavioral health treatment provider. And they conduct an annual trauma-informed survey. They have one survey for staff and one survey for their patients. And I thought it was really brilliant. They decided to frame it around trauma-informed care rather than stigma, because they were concerned that by using the term stigma, that people may evaluate themselves and the environment a little bit differently, right? Like, none of us necessarily want to admit that we're in a stigmatizing environment, but might be more open to talking about how we can make our environment more trauma informed, and stigma obviously plays a really big role in that. And so Jessica Lee, who's the treatment director of counseling services of Lancaster, is featured in the webinar. And then certainly I'll do some digging, but I think I actually have their survey questions, and they are lovely to speak with and talk to. And so if after looking at some of these preliminary materials, that's something you'd want to, you know, follow up on, Lori, you have my contact information, and we'll put our contact information up on the screen, but please reach out. I'm certainly happy to chat more about that. Yeah, of course, Liliana, thanks for the question. Any other questions, thoughts?
I just want to say how grateful I am that Liliana is already seeing an application of this information and thinking about how to enhance the care for our community. I have great appreciation for that. I also want to say another resource that Stephen brought up was the ARCORP and the peer recovery coaches conversation hour with Donald McDonald. And if anybody is wanting to get in on that too, that all you got to do is reach out to me and I can get you the link and everything so you can go in. This is part of our benefits of being an ARCORP grant recipient. And I just think that the more that we can use the resources while they last, because our grant ends at the end of August, hopefully we find another one to catch up with. But I think we need to really use those resources as much as we can. And there's lots of other ones too.
I threw a link in the chat for you all to pass along to any of the peers that are working with your programs, or any supervisors that are peer supervisors as well. They can register to attend this, you know, and it's really a sort of come as you are. There's no requirement to attend, you know, a certain amount of them. Folks even kind of hop on, listen for 15 minutes, and if they decide it's not for them, it's not for them, and maybe they join another time. So, and then he's also available to do some, TA and support as well. So we can always connect you with Donald.
I just wanted to thank you guys that this was really good information. So I work at the Mental Health Association of East Tennessee, and I'm helping develop their co-occurring disorders program. And so looking at the co-occurrence of mental health and substance use, and I think I'm very educated on mental health and stigma, but I wouldn't say I was very educated on substance use. And it's like, it's already, I feel like, hard to educate people on mental health, but then I feel like substance use is a whole other, like they maybe can accept that a mental health disorder is a disease, but substance use is a different story. So I think you guys really, it helped me a lot understanding how to, because I'm sure I will, once I develop the program and educate, I'm sure I will handle some people having some comments to say about that. So this was really helpful for that going forward.
Thanks, Sarah. I really appreciate that.
Yeah, thank you.
Might I just ask if anybody has had any successes in the community in stigma reduction that you may be willing to share as far as your approach? Whether it was a personal approach or was it an organized effort through a workshop, or did you see any strategies that really resonated with the people you were attempting to support?
Can I just talk about stigma in general, not so much stigma for substance use, but actually just this morning I was at a middle school career fair and talking to middle schoolers about mental health. And I found that my biggest thing is being vulnerable and being honest with them about my own struggles with it. And so I think that's where that peer support really comes in. But I don't know, I think being able to show them that you've gone through it has really, that's always how I've kind of addressed stigma is I feel like people have this idea. And also, so my dad drinks, and I think people look at him and see him as this high functioning alcoholic, as people may say. And so I think being able to be, as I've gotten older, I'm more open about that. And they're like, but your dad seems so nice. He seems like he goes to work, he does this. And I'm like, that's that's most people with a substance use disorder, a high number. You don't know it, you don't see it. So I think kind of changing that image in people's mind of what that looks like, and showing that sometimes it's hidden within them has been helpful for me. And people said that that's changed their mind on it.
Sarah, I appreciate you bringing that up because I still remember when I first started working at a syringe service program. Now, I'd been working in the policy field for a while. I thought I was a well-educated person. I had had my major learning curve and was kind of plateauing. I feel like we all reach a point early in our careers where you think you know everything and then you kind of realize you know nothing. And I remember when I started working at the syringe service program, and I was there by myself, and someone pulled up outside the program in an HVAC van. And this guy got out and he's, dressed in his uniform. And I remember thinking to myself, oh, he must be here to do something in the building. My boss must have just, forgotten to tell me. Great, I'll let him in, whatever. And then he, came into the program, was so incredibly friendly and pleasant and nice. And then he handed me his laundry detergent bottle of used syringes to recycle and was then there to pick up more supplies. And I was so taken aback. And I remember thinking to myself, oh, I need to do some of my own internal reflection in this moment. What did I expect people coming to the SSP to look like? And that was a humbling moment. for myself, and I still catch myself in things like that.
I think the vulnerability, that you share, Sarah, and that I think others share when they really sort of connect with others, talking about some sort of mutually relatable experience. I think all of us have in some way or another in our lives, whether it be directly or indirectly, been affected by, substance use in different ways, and or even loss. Many of us may also have lost, people to opioids. And so, having that ability to be vulnerable, to show empathy, and to show, that, there's no expectation for us to be perfect in this work that we're doing, but we can certainly strive to, work towards being more conscious and self-aware of the impact of the work that we're doing. Knowing we're not going to get it right every time, that's okay. We're going to learn every time, take those lessons and, do that self-reflection to continue to grow and educate and think about like, what more tools do I feel like I need, in order to empower myself? Are there goals I want to set for myself in my professional development, or my personal development that are going to really help me to achieve what I want or be the person that I want to be in my community and how I want to support my community. And so it's just really important to be able to have that skill set in this work that we're doing of being humble to the work, but also being really conscious of how we can spend time self-reflecting, even if the work is overwhelming. That's a sign, compassion fatigue, burnout, secondary and tertiary trauma. Like these are all other components that, day 4 of our Stigma conference that we're all going to be, attending together. These are all different topics that we could certainly always dive deeper into. So yeah, thank you for that, Sarah. So
Well, I
we're almost out of
appreciate
time. Yep.
we're coming to the end, and I have a brief poll. I don't know if I'm going to try and launch it right now. This is our evaluation, so if you wouldn't mind to quickly complete this. Is everybody seeing it? Oh, good. Thank you for the affirmation. So if you could just quickly complete this, I would really appreciate it. I will share the results then with Jordan, Stephen, and Dr. Harder, who had to leave for another appointment. But I thank all of you for attending. I think this is an extremely important topic. We do record all these sessions. As you noted, we're recording this now. I will also have links to the slides that all of our presenters have shared at the same site. I will also copy the chat and make that accessible with the presentation, so you won't lose that. If there's anything else that you might need, our website, tnopioid.utk.edu, is where we put everything. And our latest newsletter is actually focusing on rural SUD stigma. So there's a little bit more information there as well. Stephen and Jordan, I thank you so much for your generosity in sharing your time and expertise and experience with all of us today. You've given us things to think through, not only for us personally, but for our organizations and the communities we serve. And together, it's only together that we can be a healthier community. So I can't tell you how much I appreciate your contributions to our Friday afternoon and beyond. Thank you.
Thanks for having us. It's a real pleasure.
Thank you.
Take care, everyone. Bye-bye.